we are not covering the cost for all funds with the premiums alone. And then you see here the premiums versus benefits for the health care alone. You see again the increases, and you see the the expenses being above the income, the premium income. So it's not covering. Additionally, when we look here at the OZR, we see something similar happening. However, we did see in the last, so between the last year, so last year we see a decline in the expenses for the civil servant care. However, that is mainly due to reduction in costs, SZV trying to reduce their cost of healthcare. Just looking at the numbers, what did healthcare cost us in 2023? The healthcare and social fund together cost us around 275 million guilders. And when we just put that in the context of how much the budget of St. Martin is, how much does healthcare cost us, and this is not the amount that is coming out of the budget, it's covered by the premiums. But the amount that it costs, it's 56% of what we have budgeted for government. That is the total cost of healthcare and social. So, moving along. Here we see the accumulated deficits. Here we see, the accumulated deficits of the ZV, OV, FZOG, AVBZ. It's 344 million. So we are 344 million in the red for the reserves of the healthcare funds. It's actually 344 million in the red in 2023. When you look at the reserve funds being 320 million, then you see this is the reserve funds with the social funds included. The 320 million, you see where when you have a minus 344, we are now in the red completely. So if you look at 2022, when there was still 299 million versus 332 million total in the reserve funds, we were still, I would say, above water. But here now you see where we are really in need of health care financial reform. We cannot continue any longer in this way. This situation has developed over the past decade, and if we do not do anything, our healthcare funds will be bankrupt. Good morning. So the ways forward for a sustainable solution, if we do business as usual, the way forward would be to have an increase in premiums charged. This will lead to immediate revenue increase, but it will be more burden on current premium contributors. And we will have the risk of making healthcare less affordable. And it's just a short-term fix. It's no system-wide improvement, and it will be easy to implement. That's the business as usual model. If we go now to the healthcare reform, we go to general health insurance, what is called then risk pooling, then we can see an immediate broadening of the premium contributors, and we can have more sustainable and equitable financing and target the inefficiencies. And we can introduce preventative care to lower the healthcare costs in the future, and it is a long-term fix. So that's what we're looking at. If you can remember the slides before where I showed the graphs, you could see the difference. If with your indulgence, I will go back to that slide. I like to go back to this one. If you see here where the difference here between benefits and expenses is quite wide compared to here. There you can see where we broadened the base. So we added the higher income, higher wage earners, and you see already that we broadened the base, so we're already coming closer and making the healthcare affordable. So the general idea behind everything is to broaden that base. And so I can show you here with these other graphs. Again, this might look familiar to the parliamentary members of parliament who were here last year, because they, for the most part, the same graphs were used, the same presentation was given in September and October and November last year. We are sticking to the same project as a ministry. This is what we think is the solution. So if we look at what these graphs represent, the employees of the private sector. All of these graphs are looking at the private sector. Currently, they pay 5.7% premium over their wages. If we do business as usual, so just now, which was option 1, which is raising the premium so that we can cover the cost, then we will have to raise the premiums to 8.1%. If we adopt the general health insurance, the SAAHA Act, then we can leave it at 5.7% for the employees. That's the employees' contribution towards the cost. When we look at the employer contribution, the employers, we would have to raise the premium that the employers pay into the fund by 0.2% to 9% for the general health insurance. And if we do not choose that option and we do business as usual, we would have to raise up to 13.3%. Again, also unfavorable. And then when we look at our pensioners, actually 65 plus, here you will see a decrease in the premium that they would have to pay, and our pensioners are the ones most in need of health care, and this will help to strengthen their their ability to their spending power, their purchasing power. Yes, so they'll go from 11.9% to 10%. When we look at the civil servants now, civil servants pay 4.75% of their wages, and they could now go to 5.7%, which is similar, if I go back, which is similar to what the private sector was paying. Civil servants go to 5.7% as well, which is an increase of less than 1%. And if we do business as usual, if we do not implement general health insurance, it would be 8.06% in order to cover. Over here, what does the employer pay in? Government is the employer. Government pays the medical expenses at cost. So as such, we don't have a premium that we pay, but we pay at cost, and we would now, with general health insurance, pay in 9%. And business as usual, it would be around 7%, but it's at cost. And then a retired civil servants, the FSOC, FSOC has far less people paying premium compared to the other funds, and more importantly, the elderly have a higher risk and need more expensive care. And there too, you will see a decrease to 10% with doing risk pooling, with doing general health insurance. When we analyze the cost of health care, you see that the Pareto rule, about less than 25% is like 20% of the cost is being covered by 80% of the people. So once you increase the number of premium payers, more payers will compensate for the cost. This, you'll have to interpret this as being every person's cost on St. Martin. So this is every person on St. Martin, and this was their healthcare costs. So these are all the people who do not have healthcare costs. So let's call them healthy people, or people who do not know that they are sick, who do not go to the doctor now. They're on zero, so they don't have healthcare costs. You see that when you broaden the base, when you include more people, more persons, then we can raise the average premium. So then we can cover more of these costs here. So
Minister, if I could just interrupt you for a second. MP Jacobs would like you to go back to something you presented earlier. I'll allow it just so that it can be clear before you continue. MP Jacobs, you have the floor.
With the slides?
Thank you, Madam Chair. Good morning.
Good morning.
Good morning to my colleagues, the Chair, 3 feet, of course, the Honorable Minister, and the support staff from the Ministry as well as SZV. I think the information you're presenting is very important, but it is intensive, especially with the slides. I know you're a statistician, so it's easy for you to just throw that info out there, but I think for the understanding of the public, if you could give a little more explanation as to what the bars represent. So you went over that a bit fast. And even for me who's seen this presentation before, I found it going a bit fast. So if you can please, back to the premium increase compared to healthcare reform option, explaining those first 2 bars vis-a-vis what the third one is. If you can please just go over that a little slower. For the elucidation of the public. Thank you.
The minister's indicating she understands your request. So, Minister, could you please go back to that particular slide and give some more explanation?
I think this is the slide, right? This is the first one. Okay. So this slide, covers the private sector. So this whole page, this slide is the private sector versus this one is for the civil servants, first off. So now in this one, with the private sector, we all, on our pay slips, we all pay in to healthcare and social. So the blue here is the private sector. They pay in 7.5 for the ZV, and they pay in the 1.5 for AVBZ. Sorry, 4.2? 4.2 for, yeah, my eyes are not the best. 4.2 ZV and 1.5 for AVBZ. So in total, the average, the employee out there in the private sector, they pay in on their pay slips, they pay in 5.7% now. What we saw before is that this premium, I'll go back. Chop. This premium is not covering this. So this here is the premium in blue. It's not covering the costs of the healthcare. So therefore, we have to do something, and we have to do something fast. Not just fast, but good and fast. So that is why now, here, we're saying, okay, then we have to do something to cover that gap. Then we have to raise the premium to 8.1%. But nobody would want to agree to that, because that means that your salary will decrease. You will have this 2.4% that you pay extra for your health insurance. So the option that we have with the risk pooling, with making the base broader, is to keep it at the 5.7% for the employees, so the private sector employees will not feel any difference because they're already paying this 5.7%. And now the part that the employer pays in, because on your pay slip, your employer also pays into your premiums. And there, we're asking the employers to pay in an increase of 0.2% for the risk pooling, so that we can have this solidarity fund, and that is then going to go from 8.8% to 9%. But if we do not do risk pooling, if we do not do general health insurance, then in order to cover that gap that I showed earlier in the slide, then we have no choice then to raise the premiums to 13.3%, which is also, no businesses will want to do that. And then with the pensioners now, there you see where the premiums are 11.9%, and this can be lowered to 10% to alleviate them, versus because they have so much, they have so high costs in care, they would have had to raise their premium all the way to 17%, but we are not opting for that as a ministry. We are saying we can bring them to 10%. So yes. Okay, so now when we look at the civil servants now, they pay in 4.75%, and as I mentioned earlier, private sector is 5.7%. Civil servants only pay 4.75%. And now we are looking at, for general health insurance, to carry it up to 5.7%. I must say there is an additional, when I started in government 24 years ago, there was a self-pay, so we would pay in 10% of our medical expenses. However, that has been discontinued now, or it's still there, but it's not being done. And so all of that, I mean, by us not paying it, it still has to be paid by somebody. So that's where you're also getting this deficit in the coverage. So that will have to be implemented back, and the 4.75% will have to go to 5.7% for the Solidarity Fund. And so this is something that was discussed, I understand, before my term with the unions, etc., and they had a lot of questions about this, about what they are getting for this increase, because then you will see here that civil servants will have to pay in a little bit more, but if you want to look at solidarity, it will mean that civil servants will be paying the same premium as a private sector person. So then government as an employer would have then a standard premium of the 9%. And the FZOC, and just from talking to elderly in our community, we see a lot of issues with them, as indicated here below. There are far less people paying the premium, so it's a smaller group, and so this and they need a lot of care. So to cover it, we would need this 25.7%. That's 1/4 of your wages. That would not be normal, and so we're looking at 10% there. Okay, so here now, again, if we look at all of the people's cost of their care, that's what's depicted here with the blue line. Right now, the base, so who is covering that care, whose premiums are covering that care, we are looking at who is not covered. The co-insured, right now, if you are insured as a civil servant, for instance, your spouse is also insured, but they are not paying in. They are not paying a premium. So those are the co-insured. You have the people in private insurance, they are not paying into a general fund. And you have the uninsured who are also not paying in any premium. And the hurricanes and COVID, that depicts with disasters, you lose jobs, and when you lose jobs, you lose wages, and when you lose those wages, then they are not paying in either. So that is where the Solidarity Fund comes in, because all of these people are paying for these. You can see where the premiums are covering here, but it's not, at a given moment, it's not going to cover. But when you raise the premium level, then you include more people and you get higher incomes also included, and you can have a larger group compensating for catastrophic care. This over here is catastrophic care. If you want an example of, let's say, catastrophic care, when we had the performer who got shot here, the cost then, those would be these high costs over here, Medivac, and the cost of ICU, etc., this would be over here. So when we raise the average premium, we can cover all of those catastrophic incidents according to our calculations. But it's not only about fixing the financial situation. Currently, not all citizens have access to health because they are not insured. So the uninsured population is not always uninsured by choice. We have vendors, taxi drivers, self-employed entrepreneurs. Think on your cleaning lady and your gardener. I know this is a burning issue. It has been a burning issue for many members of Parliament. It is also an issue that we are looking into in the ministry. It's not their choice that they are not insured, but with general health insurance, you can bring everyone in under the insurance. Some people are not accepted by private insurers because of pre-existing conditions and or because of their age. And the premium for private insurance is not affordable for people, again, with pre-existing conditions, people over the age of 65, and children with serious diseases or birth defects. So we're not just looking at the reform for the financial reform, but also to insure all. That is what is important. Because general health insurance was also implemented in Aruba and Curacao, we look at what are the most important lessons learned from Aruba, for instance, and you see there that in Aruba, a combination of circumstances led to significant higher costs in the first 2 years because the tariffs were not regulated, were not rationalized. So they had to go back and fix those things. So we look at that example, and those are corrective measures that are in the SAAHA, in the Act, to ensure that that does not happen. When you look at Curacao, they had insufficient time for preparation. When I look at the former presentations, I saw where the former minister indicated that SAAHA it was supposed to go into effect the 1st of January 2024, and he indicated last year that it would then be 1st of January 2025. I can tell you now that it's not going to be the 1st of January 2025. It's more going to be the 1st of January 2026 now, because we do not want to have the insufficient time for preparation. What we will do, though, is parts that are ready can be implemented leading up to the 1st of January 2026. Unfortunately, there were 2 election periods in the recent past, and we need to take into account that slows down the ministry and slows down decision making. And what is then on the positive end is that you have the former Minister of Health, who is now in Parliament. I am currently the Missionaire Minister of Health, who will most likely be in Parliament soon, and the incoming Minister of Health is in Parliament now. So I see where there is continuation, and so I can only feel great things for SAAHA, that it will finally, we will make this decision to save healthcare for St. Martin. In summary, the current situation is unsustainable. The healthcare funds have serious deficits. Not all citizens can access healthcare, and so there is a need for solidarity and risk pooling. And we need to have the sustainable, affordable access to healthcare. I have quite some more slides, but they will go faster. But it's just I still want it because it's also for the awareness of the public. And not all MPs were there last year when this was given. So I wanted to give all of the information. So can we afford SAAHA? How will the financial situation improve without significant premium increase? At this moment, all costs for the expensive care is already covered by the government and by SZV. We will be adding premium payers, not consumers of expensive care, to the pool, and this is based on research done within SZV. And so with more solidarity, the young and healthy and wealthy will compensate for the vulnerable elderly. So you can see that the higher wages, their premiums will be higher, so there'll be more money coming into this solidarity healthcare funds. And total income, instead of only the salary, will be taken as a base. So when you look at it, with the risk pooling, we will be adding co-insured, we will be adding the not insured and the privately insured and civil servants. So we will be adding to the pool. And again, as I showed the graph before, by adding to the pool, you broaden the base, and then so the premium can cover the cost. So SAAHA is only part of the solution. We are also looking at increase. So we're looking at increasing the premium income. We are looking to ensure government contribution. Government compliance has to pay for the cost of the healthcare for civil servants especially. And also we're looking at lowering our medical expenses, and there on the top point is lowering the medical referrals. This goes hand in hand with the building of the new general hospital for St. Martin. Then we are hoping that way to lower medical referrals, but also my team, we visited Cali to look at how medical referrals could be lowered, because we saw an increase in medical referrals, the cost some places, and so we looked at ways that it can be lowered together with SZV. Also to address government debt, we have made a team with SZV and the Finance Department, the Minister of Finance, the Ministry of Finance, to work on debt agreements. And we're also looking at additional income for government to cover, to have healthier health financing reform. Will people lose entitlements with the SAAHA? We do not believe that people should lose any entitlements. If we look at the comparison with the rest of the Dutch Caribbean, the population of St. Martin should be offered no less than others in the Dutch Caribbean. So similar packages for prevention and primary and secondary care, and equal chance to survive cardiovascular events, which is already taking place now, and similar life expectancy. So we're also looking at, for the near future, to be able to have more expensive care, such as rare diseases, life-saving treatments, and extremely expensive treatments. And will people lose their entitlements? No, to the contrary, the packages are rationalized and improved. So we've added actually to what is being offered now, and what is added is the preventative care, second opinion, dental care, optical care, maternity care, and anti-conception. Who will be eligible for SAAHA? All residents of St. Martin, as well as non-documented persons who pay taxes for labor for more than 20 hours a week. And it's important to note that more than 70% of the population is already insured with SZV, and SAAHA will not change a lot for them. Moreover, the majority of the privately insured persons will move from their private insurer to SZV, which will contribute to the risk pooling, and a large part of the currently uninsured population can now join SZV, which gives them access to health and ensures that all citizens contribute to the health system. So you'll see that here we have what is already covered, and so now we will add the private insurers and uninsured to have a broader base. The following persons will be excluded: undocumented persons without a job or a job for which they do not pay taxes, and or if they do not work more than 20 hours. This is to prevent abuse of the system. Also, the people who opt out will not be included. So, opting out, is it possible to opt out? Yes, it is possible to opt out. However, there are some conditions. One-time option at the introduction of the SAAHA. Only persons who are already privately insured at the moment, and inflow into SAAHA is possible annually on January 1st. And after that, you can't opt out again. Furthermore, we will prevent calculating behavior. So the whole family has to opt out. So there are different measures that were put in place to make sure that people do not take advantage of the situation by opting out. There is also a one-time opt-out fee, a solidarity premium that has to be paid, and you can see that as if you opt out, but then later you let's say you lose your job, or so you're not employed there, but we would need to take care of you, then to cover that for the solidarity of that, you will need to have paid in for the solidarity fund, so for the opt-out fee. So in order to, as mentioned, we would like to prevent exploitation, and we are looking here now at exploitation by non-residents. How do we prevent this? Healthy foreigners with an income are welcome to join our health system. However, we should bar undocumented persons with who work less than the 20 hours a week, and seasonal workers, as well as implement barriers to prevent medical migration, because that we have noticed does take place, and so that is why there will be then a waiting time of 6 to 12 months before you can, when you move here, that you can become part of the fund to secure the fund. When we look at, is SZV capable of handling the SAAHA? We think so. SZV has made major improvements since its establishment in 2010. If you look at the financial position of SZV, you see where there have been a span of 3 years with positive financial statements. They have been able to maintain the unqualified auditor's report 2021, 2022, and most recently 2023 as well. They have demonstrated progress made in compliance, and we're working on the outdated legislation. This is work that has continued, again, in reviewing what was presented the last time on this subject matter. We have continued in the ministry with what has been started. So we believe that SZV will be a good tool to carry out the SAAHA. And how is SZV supervised? SZV is currently supervised by the Minister of ASR, who sets the budget, who approves the performance contract. After evaluation, they comply with the standards of the institution set by the minister, and we receive the annual reports with accounts reports and bank statements, and the calculation of the annual contribution to the Landskas, to the country budget. And SZV is also supervised by the Central Bank of Curacao and St. Martin. How will the public be informed? There is a awareness campaign, public awareness campaign, and the goals of the public awareness campaign is to increase the public's knowledge and understanding of general health financing, to educate the public on how the health funding system works and its benefits, and to highlight the collective benefits and solidarity aspects of the health funding system. So the public awareness campaign has been approved. We're just waiting for the rollout. The steps are, there's an integrated marketing calendar, presentation to stakeholders, which started before my term, and we continued with that. We aligned the integrated marketing calendar with DCOM, capture real-life stories, so we really want to appeal to the people by having real-life stories, create content element for the campaign, and we want to go live with this campaign as soon as possible. You will see the team behind this presentation and the team behind general health insurance. There's a clock all the time, and that has to do with, this is something that we need to do as soon as possible. So we want to be able to start with this, but we need to follow the steps. So the current status and the next steps, in summary, I don't know if I need to go over why we need it again, why we need the financing. I think we just said that, and etc. But the next steps now, it has been mentioned a number of times, the general health insurance, the SAAHA, it is now at the SER. Because as mentioned before, the board has now been established. It is a priority of the SER. They just had their first meeting, and now they will be moving over to looking into the various projects, because there was a backlog of about 2 years that not much could have been done. So, but the SAAHA is a priority. The current status and next steps, we have had consultations with Yezet in Way, so Yurisa Zaken, with the SER, with the Council of Public Health, WICSU and PSU, CCSU, Employer Council of St. Martin, the Tripartite Council. Again, all of these before my term. This is what the ministry has done. And since I have been there, we have had the healthcare stakeholder consultation as well. And we have had SER consultation. The challenges, as mentioned just now, SER was inactive since Q4 of 2022 until Q3 of 2024. And executing entities need at least 6 months to prepare before we can implement. And so once the advice of the SAAHA is received, it will be processed for an urgent request for advice to the Council of Advice. And I can tell you that the advice for the Council of Advice is already ready. So we are just waiting on the SAAHA advice. When I checked in with the SAAHA, the best answer I can get is before the end of the year that we can get the advice back. So we're just hoping. We have done everything that we can to make it easier for them to render their advice by giving them not just the ordinance, but giving them also the slides so that it could be more understandable, because the document is quite thick, but with the breakdown, and also we will have a presentation with them as well to make it more understandable. Thank you.
Minister, thank you so much for that presentation and your elucidation to the presentation. And of course, now the members of Parliament have the opportunity to react to the presentation, ask questions, ask for clarification. And I look to the members of Parliament. I see MP Artwell Irian requesting the floor. MP Irian, you have the floor.
Good morning, Madam Chair. Good morning to the Kafir. Good morning to my fellow colleagues. Good morning to the Honourable Minister and her support staff, and SAAHA. Thank you for the presentation, Madam Chair. And before getting to the questions, I'd like to say that based on my observation of the presentation, this looks a lot or very similar, or maybe exactly the same as Ottley here, but was referred to as before. And it's a little, let's say, even surprising, because we had clear opposition from, let's say, the now current Prime Minister. I mean, to a point where even a few years ago, a motion of confidence was brought towards the, no confidence. A motion of no confidence was brought towards the former Minister of Health, VSR, Emily, basically because of this same, similar proposal. And today, with confidence, we see that it's continuing. When the former Minister of VSR, now current Member of Parliament, Omar Ottley, when he assumed his position, he inherited basically a situation where a hospital was proposed, a bid was won, a process had already started, and because of a change of government and opinions, for example, we spent millions, I would say. I'll let the government respond to that if they would like to. Millions in having to pay a company out of their bid that they won, and to avoid, let's say, basically a settlement going forward to then start a new hospital again. That then was delayed for a few years. And he assumed that role and started then continue the process of trying to establish, ensuring that SAAHA doesn't go bankrupt and without, or the people don't suffer without proper premiums. And during this time, we've also had certain discussions as Minister of Finance and Minister of SAAHA, Minister of VSR and SAAHA, on the feasibility of and survival of this whole system. The hospital was supposed to be there to lower the cost of us going overseas. That was the initial reason why. And in the initial calculations, that, hey, you know what, if we have our own hospital, the cost of going overseas is reduced and we can cover this locally. What we now see, though, is that we are establishing the hospital and possibly still having the same amount of referrals outside, which means that we're going to have a similar cost. I see an eyebrow raised. I would like to then ask then, and have an answer from, let's say, SAAHA. if you look at the current trend of referrals abroad and the cost of healthcare, would you say then that we are saving money to that's similar to the initial plan that we had? So initial plan was we will reduce costs by having less referrals. Based on the current trend, 5 years short, 10, 15 years long, do you see that plan being the same? With that data, would you then say that without raising premiums, that it is sustainable for us to have the hospital? And a very direct question. Without raising premiums, would you say that it is sustainable for us to continue on the current track with the hospital? And I think that with those, we would then have, with those being answered, then other questions will be posed. Regarding the civil servant solidarity, I'd like some clarity, because I forgot myself. How long have they not been, let's say, paying into this? So how long has this situation has existed? Is it since 2010, or is it before 2010? While we were trying to deal or fix the situation with the civil servants, we also had meetings with the unions, etc. The Prime Minister also had meetings with the director, and we established, hey, yes, this is an issue. We had very, very tough meetings with the civil servants and the unions, and at some point in time, you have to start contributing. But another issue arose where we said, okay, SAV, start. SAV said, no, this is not for us to do. You have to establish a department and administration to be able to handle this. So I asked SAV, okay, why? They said, because it would cost too much for us. And I said, but if it's going to cost too much for you, it's definitely going to cost too much for us, especially during the pandemic. So it became a battle of the too much cost for us, blue and red. So how does, because I didn't see it in the presentation, I understand the situation, but I didn't see the cost in the presentation. I didn't see the effects in the presentation. So what is the government planning to establish this department, or an extra administrative layer within AZ or VSR to handle this? What does this department look like? How many staff? Or what does if it's not a department, how many extra people are you going to hire for this position? Where in the function book would it lie? Would it be consultants? So how do you plan to establish this administrative procedure? What would it cost us to be able to do this? When we looked at the data then, and I stand to be corrected, the cost to establish this department, pay people to handle it, was almost as much as the amount of the civil servants had to pay in. So then it became, okay, so if that's the case, you might as well keep it the same way. Because if you're going to go through all this work to then have the same amount of expenses or loss, for example, then does that make sense? Just to say we have a department or administration doing it the right way, yes. But now, let's say the civil service now are negatively impacted unnecessarily, because then you might as well keep them on the same track, because the expenses or costs will remain the same. My next question was regarding the SAV service level agreement with management of the building. How does any of this affect that, and how far are we with that in terms of the contract with SAV and managing the building? Also, how far are we now with the discussions on, because before we left, we had basically an agreement of where we stood on the amount owed by government to SAAHA. We went through a process with SOAB and so forth and the Ministry of Finance and SAAHA came to a final number in terms of, okay, this is the number we agree on, and we move on with this, and starting 2025, the agreement will be executed. Has discussions continued on that topic? Has the figure changed? Does this current government agree with the position that we had before, the figure we had before, and will the agreement be signed before the end of the year so that it could also be reflected in the budget 2025? I think a lot of things, I can imagine the budget 2025 would not be here anytime soon because all of these discussions have to be put in the budget 2025. It has to be finalized. So the agreement on the management of the building, which option did we choose, how does it affect any of this and affect the finances of SAAHA and the government? In the presentation, it mentioned the overweight and diabetes percentages. So my question here would be, how will the proposed SAAHA system address the high prevalence of overweight, which was, I believe, 70%, and the diabetes in St. Martin population? There's also data that we had before. And what steps are being taken to improve the preventative care and health awareness among citizens in general? So for us to lower the amount of cost to SAAHA, if we push more preventative measures, then we could potentially reduce the cost to SAAHA. What specific measures will be implemented to prevent overconsumption of medical care and reduce unnecessary referrals to specialists? Going back to the presentation years ago, and we had the individuals that helped set it up in Aruba when it failed. I believe you mentioned that in the presentation also. It didn't go as well. They also came here, and one of the issues were that persons were abusing the referral process. So persons would, let's say, go to have special procedures done every single month without, let's say, being checked properly. So how would you avoid those? What is this government's position on addressing the issue of the gray economy and ensuring a fair contribution to the healthcare system? We had our position. I would like to know the position of this government. Believing as if we, during the creating of, dealing with the pandemic, we saw about, I believe it was 3,000 persons that were on SAAHA, but let's say were not properly registered on the island. So what are we doing to address the gray area in this? And my last question for now, how does the government plan to address the balance and need for comprehensive coverage with the financial constraints of the healthcare system? That'll be the last question, Madam Chair.
Thank you, MP Irian. I now give the floor to MP Jacobs. MP Jacobs, you have the floor.
Thank you, Madam Chair. Good morning again, officially, to my colleagues, to you, Madam Chair Nakrifir, as well as to the Honorable Minister and her support here this morning. First of all, I want to thank the Minister for the presentation and for the statements of solidarity with the continuity of all of the hard work that has been executed over the years. I think going back even further than the previous government to mention what had been done before, and of course commending the hard work of the civil servants, those other stakeholders within healthcare, especially SAAHA, the GPs, and all of the other stakeholders, of course, not to mention the most important ones, the people of St. Martin, who have been hearing about this now for quite some time, names notwithstanding. Thank you also for going back over the numbers to really explain and show it in the graph, because I am very visual, but the explanation going with the visuals have to be clear. And I think while that slide with the bar graphs was clearly explained, there was one that started, yes, the financial urgency for healthcare scheme. I didn't want to stop yet, too many of them, but seeing let's say the null line, the bottom line, where you're seeing the 320 million, I think when people look at graphs, if they're not seeing the numbers, they're like, oh, but we gone to zero. So I don't think, I don't know if in presenting that information, it can be clear that, yes, we were in worse stages and now we're getting where we need to go, and we need to definitely implement this legislation to have a better chance to be able to afford healthcare. But in presenting it, that like going down to like where normally a zero would be, for the visual impact, I think we should be a little bit careful with that. So we're not at zero, correct? Good. The urgency for the reform has always been something that we 100% support as a faction and also while in government. The increases, I think my colleague discussed this, touched on this a bit, but I would like to be quite clear. The increase that is projected in the center slide, the purple one, the purple bulk bar, would be the situation once the healthcare insurance is implemented with the risk pooling, or is this already possible before the legislation is implemented? One, the risk pooling bar, that represents the change, correct? So once the legislation is implemented, you're saying by 2026 now, gearing towards that. For me, it needs to be clear, especially with the civil servants' projections, from 4.75 premium to 5.7, like the private sector. Does this include still, or would the 10% pay still become a part outside of this increase? That is not clear. So does this increase include or preclude that would not be necessary anymore, which was then, answer the question of MP Aaron as well. So make it very, very clear as to how this will impact the civil servant in terms of premium as well as copay. And in that regard, I think persons who travel and maybe have to deal with living outside of St. Martin would actually realize, as much as we complain about our medical coverage, we have pretty good healthcare coverage or medical care coverage on St. Martin. I have experience in the US, the copay even for mandatory physical therapy after surgery for a recovery, is to the point where the persons cannot afford it. So I think around the world, medical insurance and healthcare is a very high cost, and that we as a small island, we're blessed that we do have the SZV, but yes, we're running into the risk if we don't adjust to the realities of the premiums we're paying right now vis-a-vis the cost. So I just wanted to say that for the record. What we have to pay for surgeries outside and the copay with whatever insurance you have is much higher also in the Netherlands. I would like to know what was the outcome of the stakeholders meeting held with the healthcare, the one that was held recently with this current administration, in terms of is there any changes or requirements being requested from the healthcare stakeholders. I understand that the set is finally in place. We had expected it to be much earlier, but yes, we do know about the ILO interventions and actually interventions that started based on actions from employers on St. Martin. So how impactful, and are we aware of the sentiments of employers on St. Martin regarding this proposed healthcare system, and what risk does that pose for the implementation? Some of the risks, or not risks, you mentioned lessons learned from the implementation of similar systems in Aruba and Curacao. I would like to know, where are we with our tariff assessment on St. Martin and or adjustments? I know in previous presentations we've heard the hospital and others talking about the challenges with tariffs. Have our tariffs already been assessed and or adjusted to meet the needs, or is this still part of the timeline in the implementation moving forward, and where does it fall? So we saw a little bit about the historical timeline, a short piece, at least 2024. What is the timeline? I understand you said for the end of the year, for the SAAHA advice, the Council of Advice is more or less ready. What is specifically needed in terms of actions once these advices are there? Is it the tariff assessment that still needs to be done? Is it or adjustment? Is it that you mentioned something about Curaçao's challenge was the maximizing the participation percentage of the population, but your opt-out presentation didn't put that at ease for me that we would not face the same challenge. So how are we planning to limit the opt-outs is the question in that regard. Something else that caught my attention was that total income would be used versus the salary as a base for the calculation of the premiums. Is that what will make it 5.7, for instance, for the civil servant? Or will that 5.7 then reflect a much higher number, because currently the 4.7 is on the base? So if you can use a real example of a salary slip from a private sector and explain how, with the current situation, this is what you're doing, this is what you're paying, and then visually also for a civil servant salary, doesn't matter what the salary is, just what are we paying now in terms of premiums, what is the government contribution, and then with the new situation with the risk pooling, what will it be, including how that impacts if it is a projection to do it from the total income instead of the salary. I also heard the minister mention, I haven't once said Madam Chair through you, but yes, all of these questions are going through the chair. What are the options being looked at for increasing the income or revenue of government to be able to do more, increase our contribution, and decrease the arrears still owed to SZV? So is there a specific health levy? I've heard that in the past. Is there going to be something specific that is mentioned as health, or is it just going to be incorporated in some other way? So that needed to be clear for me as well. Hope that question is clear. And I think I asked the one about opting out already. What steps are we taking to minimize the opt-out? And what exactly is meant by the solidarity premium? What is meant by the solidarity premium that would still be paid once someone opted out? And how is that calculated? Another question I had, Madam Chair, would be is in the process towards 2026, which is another hope, another target, what can be currently done to increase coverage or to offer coverage to self-proprietors such as taxis, taxi drivers, bus drivers, vendors, and other SPs who are currently not covered. I know that discussion was already ongoing, and I was under the impression that it was already available. So if it is not, what is possible in advance of the legislation via whether policy change in SZV and or government? Something that I've heard also internationally, and when we've done the United Nations type discussions, healthcare also comes up. And there are some people who are stating that we are talking about a healthcare system, but what we actually have is a sick care system. So I would really want to know what, if it is our vision to have a more healthy population. We have done these surveys in terms of how healthy is St. Martin. That has been now several years ago. When is the next one projected, or has one been recently done? We know and we have heard recently that, I think within our regular census, that hypertension, diabetes, and other obesity-related diseases, heart disease, has been on the rise, and that the ministry was focused on the prevention of these non-communicable diseases, the NCDs. So I would like to know, in terms of the ministry's vision, are we still going towards a healthier population? And what are the investments in preventative measures to ensure that we are paying less for healthcare, and in not only increasing what we're paying in premium, but actually bringing down the cost in terms of the diseases? I know that, and again, I know that there was a project program ongoing for this. Could the minister also update what has been the impact to date of the ongoing project program awareness for preventative measures? I know we have the Health Expo and other things. Are we seeing an improvement as yet in the numbers? And in fact, is it possible now, because this was one of the things, is it possible to have the GPs report on these on a regular basis, whether to the health department and or CPS and or SZV, who is carrying the brunt of the cost? And one of the last questions I have is whether the long-awaited SAAHA advice is a binding advice, and whether or not we can get, as government, advance copy of the Council of Advice, because I know the NADA report, the report after the advice, also takes some time. Would it be a suggestion to already have a look at the Raad van Advies advice, Council of Advice's advice, to start the preparation to deal with what they may or may not have suggested while awaiting the SAAHA advice? I'm just wondering if that is possible. That as government, we already work on whatever the Council of Advice may have advised while awaiting the SAAHA advice. Madam Chair, that's my last question for now. I believe my previous colleague had already touched on some of these questions, and I 100% support that we go towards a more comprehensive healthcare that has a greater amount of participation by the population, thereby bringing down the cost and, you know, the more paying for the less in that sense. So I would like to see this move, and I would hope that 2026 is all the way there, but we actually get it done before 2026. Thank you, Madam Chair.
Thank you, MP Jacobs. I continue and I give the floor to MP Gums, MP Melissa Gums.
Thank you, Madam Chair Lady, and good morning to you, Rifir, my colleagues, the Minister, her support staff, and those joining us online or by radio. Madam Chair, I just have two main questions right now. I believe the Minister, and maybe I should have interrupted earlier, mentioned that anti-conception methods were kind of included in some of the preventive care, but I would just wanted to ask if, through you, Madam Chair, the Minister could clarify that. When I previously asked about including contraceptive methods as part of a move towards better women's reproductive health, SAAHA's response was that birth control is available over the counter, so no. But of course, contraception goes beyond the pill, IUDs, the patch, etc. And I just want to get a better understanding of how has women's reproductive and general health been taken up in the SAAHA, because certain contraceptive methods don't just help with family planning and preventing pregnancy, it helps with endometriosis, certain forms of PCOS, etc., which are all very painful conditions that lead to further healthcare complications. So it is a form of preventive care, if you will. And then how are mandatory screenings also taken up in this? Because general healthcare is nice, but if you look everywhere, even in more advanced systems, they're all under strain. Even if you look at France right now, they are scrambling to find ways to pay for their own very broad universal healthcare system, even with all of the persons that they have paying into it when we talk about economies of scale. So I just want to know how are mandatory screenings taken up in this to ensure that we get a kind of effective preventive care to prevent that we are adding people, but then we're also spending more as we add persons to pay for this, or the young, healthy, and wealthy, as was said in the presentation. And I'm talking about pre-screening, of course, for certain forms of cancer, cervical, prostate, breast cancer, and the like. And MP Jacobs also asked it, I had it as a question as well, the solidarity premium, even when you opt out, if we could get some more information on that and what that would look like and how that would be brought across. Because if I opt out of something and I still have to pay into it, I would like to know why and how that would be brought across then to the persons who would have to do that. And that's it for me right now, Madam Chair. Thank you.
Thank you, MP Gums. And let me add to my colleagues' questions and comments a few comments. I saw MP Irian, but MP, you had spoken already. Just wanted to add something briefly, then I'll allow you to do so before I continue. MP Irian, you may.
Thank you, Madam Chair. Yes, I just want to add, similar to what MP Gomez mentioned about the opt-out, I wanted some clarity on the opt-out. And also, can civil servants opt out? So is it just for the general public, but also can civil servants opt out? And to follow up on a question posed by MP Jacobs regarding the bus drivers, and if something can be done in the short term, I'm 100% sure that it can, MP Jacobs, because we already have a system in place where the taxi drivers have something already. So it can't be, we can't discriminate, right? So the taxi drivers have insurance, there's association, they pay into the association, and the association covers then the insurance. So my suggestion to the minister, to Madam Chair, would be if we could, and this is a discussion that started already, so it's not something new, if we could just have an association created for the bus drivers and have the similar system that was done for the taxi drivers done for the bus drivers. Thank you, Madam Chair.
Thank you, MP Irian. As I started to say a moment ago, let me add some questions, Minister, to those of my colleagues. But before doing so, I want to thank you for your very elaborate presentation on this very important matter. The Minister, let me dovetail on the issue and the questions regarding mandatory screening. As you know, it is something that on several occasions I have brought up, not only in Parliament, but publicly as well. It is based on these comments that a budget amendment was made in order for Parliament to be able to push for mandatory screening. In this context, contact was made with the Foundation for Fundación para Prevención on Curaçao regarding the way that they approach this as a national matter. And these discussions with that foundation, again, from a Parliament and a Parliament committee's perspective, will continue. But I want to stress the need for such and the importance for such in terms of preventive health care. Can the Minister also provide some information regarding implementation / execution of the recommendations in the NCD policy plan, non-communicable diseases policy plan. The plan has been shared with Parliament some time ago, and thus an update in terms of implementation, execution of the points mentioned in that plan. Is there an implementation plan of this policy? Can the minister provide an update as to the review / update that is taking place or should take place in connection with our mental health policy, which is being updated from what the Parliament has been told on several occasions? Then, Minister, I would like to address the question, what's in a name? And you have rightfully so indicated your approach in terms of continuing with what you met there. But I would like to know the official draft ordinance that is with the SAAHA at this moment. What is the I guess the ordinance is in the Dutch language. And what is the Dutch name of this ordinance? And I ask this, Minister, not to belabor the issue, but as you know, the reason that our laws are called ordinances is for a reason. And the fact when we talk about wet, we don't talk about a wet of St. Martin, and there's a reason why we don't talk about a wet, and we call our laws, we call them ordinances. So I just wanted to know how formal is the use of the name Act in an ordinance of St. Martin, if that can be elaborated on. Then, Minister, your predecessor, I nearly want to say maybe predecessors, including not only the Minister of VSA, but also of Education, have heard on numerous occasions from me here in Parliament regarding the issue of vaping. Not too long ago, Minister, I sent you a letter referring back to the many letters that I have sent and the responses that have been given here in Parliament regarding the harmful practice and a very prevalent practice here on St. Martin, especially where our youth is concerned. And Minister, if you at a time, and this is in my letter to you, Minister, the question, because I was informed here in Parliament, Parliament was informed that the ministries of VSA and ECYS have created an interministerial committee / work group to address this matter of vaping. And my questions to you was how far that has gotten, if anywhere, and just to give me an update on this matter. In a letter to your predecessors, I also indicated some ways that this matter can be tackled. In the meantime, we have proposals for amendments to our tobacco law, etc., but there are also some lower, and I mean on a legislative level, lower areas that we can address the issue, or at least commence to address the issue of vaping. The Minister, I ask you for an update on the mental health policy, if that is possible, and maybe also the larger project regarding mental health on St. Martin that is on the way. Another matter, Minister, that I have addressed to you, because I addressed it to your predecessors, is the issue that, and several of my colleagues have referred to it as well, the issue of the insurance of sole proprietors, vendors, taxi drivers, and bus drivers. We know how for some taxi drivers it has been made possible for these persons to get insurance. However, for the majority of sole proprietors, that is not the case. I was informed and asked to have some patience where this is concerned, because there is supposed to be a reparation legislation that would include these persons in the medical care, the health care. And so Minister, I would like to know from you, where do we stand? One, is it beyond a shadow of a doubt that the categories just mentioned will be able to receive health care coverage with the reparation law, which was, I don't know if it still is, at the Council of Advice? If not, Minister, I have also presented to government a proposal how, in my opinion, via a LBHAM, this matter can be easier addressed by including these persons in the summary of who is considered an employee, which can be adjusted by LBHAM. So, Minister, if you can give some information regarding the reparation legislation that is in circulation and whether that would clear up, not would clear up, would offer health care. Minister, the matter of the STEPS survey, which has been, from the last information we received, is still ongoing. Has it been concluded, and why has it taken so much longer than originally anticipated? And then, Minister, you refer briefly, or you mentioned it as an example of extraordinary cost, and your example was the artist who unfortunately got shot on St. Martin. Is there an indication, albeit just a global figure, of how much money the country actually had to spend because of that unfortunate incident? And then, Minister, where are we with the adjustments that are envisioned for the BIH legislation? Minister, I would, but before, of course, I allow you to respond to the members of Parliament, I see MP Egbert Duran requesting the floor. MP Duran, you have the floor. Thank you once again, Minister, for your presentation and elucidation. MP Duran.
Thank you, Madam Chair Lady. Good morning to you, my honorable colleagues, the honorable minister, support staff, and SZV, and a special good morning to the people of St. Martin. I have a few brief questions and remarks. I heard the minister discuss the point where civil servants paying into the premium, well, government paying into the premium based on the OZR. I know that during our last tenure, we made an arrangement with SZV to allocate land so that they can pay 60 years in advance to sort of offset costs. I also heard the minister mention about revenue generating via interministerial. So correct me if I'm wrong. What are the exact, or can you elaborate on some points through you, Madam Chair, on how the Ministry of SAAHA and Finance intends to find different ways and means to generate revenue for such? Through you, Madam Chair, Minister, while healthcare covers essential medical interventions such as prosthetics, heart transplants, which are critical for patients for their recovery and the quality of life, could you clarify why dental reconstruction, for instance, such as replacing loose teeth during accidents, are not covered? Because this can also be seen as an accident. I know that many persons have issues where this is concerned, and I believe that this is very important for not only physical, but also mental well-being of individuals. Can you give some insight into that? And I know that based on the point that was brought forth with in this case, the unfortunate incident with the international artist, I know I could remember when I was acting minister years ago, there was a situation where basically advice was given not to fly out someone that had no insurance because of the cost and also because of the critical state that they were in. But, you know, as a leader, it's difficult to play God, so to speak. So I still opted to approve it, and the person ended up succumbing in the air. I know that this costs the country a lot. I would like to know through you, Madam Chair, are there ways and means that we can look into some sort of insurance for instances like that? It might sound a bit strange because it would be like insurance, looking for insurance. But I'm trying to find out if there are ways and means that we can find a way to lower those costs, because I know that it costs the government tens of thousands, if not hundreds of thousands of dollars on a yearly basis. And in closing, I would like to say that I like the fact that the minister highlighted the point that the former minister is here in Parliament, the incoming minister is here, and you will be coming to Parliament in the near future, because it shows a sense of continuity. I think that in issues like this, when it comes to healthcare, it is very imperative as leaders that we really see our common interests and highlight those. And I believe that the sooner the better, because I think that this can only help in pushing SZV and being able to sustain this initiative. So I look forward to clarity and answers to the questions posed, and thank you for the opportunity.
Thank you, MP Duran. I see no further need from members of Parliament to... Oh, we do have someone. I just did not see it appear on the sequence, but I invite MP Ottley to take the floor. MP Ottley?
Thank you, Madam Chair. Good day to the Honorable Minister of SAAHA, her support staff, and my honorable colleagues, and the viewing and listening public, of course. I have a couple of questions. I was expecting the presence of the Prime Minister. It's a shame that he's not here. I really would have liked to get his sentiment on certain things. However, you are the Minister of VSA, Honorable Jansen-Webster. So through you, Madam Chair, I'll ask these questions. Given the current Prime Minister's vision expressed in Parliament in 2019 and his vision expressed recently, I quote, "You cannot have a sustainable financial system for your healthcare based on 40,000 persons. It is not possible." And again, in the budget debate in 2019, he expressed his disbelief in the concept of a universal health care. Are you, through you, Madam Chair, to the Minister of VSA, your personal opinion? Are you in agreement with such statements? Is the mind frame or the thought process of your party leader, your Prime Minister, still the same, or is it different? I ask this because it requires a calm decision. So it is imperative and important to understand the vision of not only the Prime Minister, but your party leader. I'm pretty sure you have one line of vision. Also, by the said indicating before the end of the year, with no set date, it is safe to say that the January 1st, 2025 deadline will not be met, as there's still processes to be done even after the said. Was this discussed with the CFT? I'm pretty sure it's discussed with the TWO, but was it? And if so, what was the response of the CFT and the TWO? Again, also, in the Prime Minister also stated that he does not believe in the increase in tariffs. Now, in a perfect world, of course, but through you, Madam Chair, when I was sitting in that position, I do know the request of doctors and healthcare physicians and many others that have screamed and kicked for an increase in tariff because they have not been increased for many years. What is your position, through you, Madam Chair, to the Honorable Minister of VSA on the increase of tariffs? Also, but as echoed by my colleagues, the SZV 1B. The SZV 1B would allow the taxi drivers, sole proprietors, bus drivers to receive insurance. However, not only that aspect, it's also the aspect of formalizing 62 plus. SZV now does it on a humanitarian basis because, of course, everyone, especially our seniors, deserve to be insured. But however, the process is for a senior, you go to the government building, you request government insurance, and then you are denied based on your age, and then sent to SZV, and you are given this on a humanitarian basis. This is a lengthy process. So in this legislation was also the formalization of that. Also, something as simple as formalization of medical referrals. Believe it or not, the legislation currently only allows us to refer patients to Curacao. These are important factors. Now, the chairperson stated that she was updated that it was at Council of Advice, but it actually came back from Council of Advice, and then the only thing required is a NADA report. I would like to know the update on this NADA report, because it did come back from the Council of Advice. How is the government intending to address the growing depth of healthcare costs and the growing number of undocumented persons? I see that the comment through you, Madam Chair, was made of the incoming minister. So I am assuming that dialogue is being had. And the comment was also made that basically we're on the same line. So I would like to know if discussions, I know that a transition document will be left, but considering the same party, is discussions already being had with the incoming minister to ensure continuity and him being in the same line. We speak of the opt-out. I think that the opt-out is important. It allows persons to have freedom of choice. However, with the opt-out, there's a solidarity fee. And I know we had a meeting with stakeholders in the absence of the said, and these stakeholders had a bit of an issue with the solidarity fee and the way that it's calculated or will be calculated. So what I will ask is, has this calculation been adjusted, the solidarity fee I speak of? Did this adjustment went back to those stakeholders that had an issue? Or are we just deciding then, now that the SAAHA is activated, to just wait on the response from the SAAHA? While the SAAHA, Ottley Cares, covers employees for a minimum hours per week, I would like to ask, is there a way to look into a supplemental insurance? I asked this question even when I was minister to who was then in charge, I don't know if it's still the same, Javier, for a supplemental insurance for those who work less hours. For example, in America, there are insurance based on what you pay that will cover 30 to 40% of your medical costs. Believe it or not, this actually is a big help. And it actually helps your health care of your country, as opposed to persons staying home and waiting for emergency to have their health care covered. So that is also an option. Also, the solidarity fee is important, I must mention, because many persons refer to Curacao in their first attempt that it was not successful, but it was due to that they allow persons to opt out without a solidarity fee. So the solidarity fee allows the continuance of some sort of income. So I do agree with it. However, I need to know, was the issues stated by those stakeholders addressed? There was a health survey being done. Is this health survey completed? If not, when is it expected to be completed? If so, can we be given the results of such health survey? I move to something that is near and dear and very important to me, the St. Martin Diagnostic Center, the HAP. Will this contract be renewed through you, Madam Chair? If so, when? If not, why? I know and understand that SZV said that it is a bit strenuous on the budget of SZV, but I urge SZV to indeed find a solution. If taken an average, the HAP since September has seen 6,977 patients. Taken an average, it's over 600 patients a month. Of course, it won't necessarily be like that. Some months will be more than the other, but let's take an average. That's 600 patients a month, whereby of these 6,977 persons, they would have had to gone to the medical center. Of that amount mentioned, 97% were non-ER cases. Again, 97%, which means that a majority of these persons would have gone to the medical center and indeed created a long extended wait and, of course, a strain on the already burdened medical center staff. Now, if SZV is not able to cover such, what is happening? 83% of those cases were covered by SZV, which is 6,069 patients covered by SZV. Should the HAP be able to should not be able to continue or continue on their own merit and only take cash, that means that these persons will no longer be served at this location and therefore, again, have to be taken back to the medical center. I must commend the staff for their tireless work, the staff of the Ministry of VSA, tireless work. What we speak of right here, Madam Chair, has been long coming for many, many years. Even like I stated before, my tenure. But however, a lot of progress and adjustments has been made. There were also over hundreds of questions that we answered to the different unions. I would like to know, while I was there, we did not receive a reply from any of the unions. I would like to know, did a reply come in from any of them? If not, then we're on the right track as well. And like you said, the SAAHA is up and running. So I look forward to the continuation of this process. I don't expect it to be completed during your tenure, Minister. So I hope and look towards the future incoming minister in hopes that this can be completed, because St. Martin do need this. So I reserve any questions for my clarification based on the answers. Then that'll be it for now, Madam Chair.
Thank you, MP Ottley. We now seem to have gone through the list of members of Parliament who wish to speak on the topic. Minister, I will adjourn briefly so that we can caucus on the furtherance of this meeting. Meeting adjourned for 5 minutes. Good afternoon, and members of Parliament. Welcome back to this meeting. Minister and support staff, all tuned in. After a brief adjournment following the presentation by the Minister on the topic at hand, as well as questions by members of Parliament, and a brief caucus with the Minister will now indicate the timing or time that she believes is necessary in order to return and respond to the questions by members of Parliament. Minister, you have the floor.
Thank you, Madam Chairlady. If we can return by the 19th or the 18th, but the 19th would be better for us, the 19th of September. If that is possible, then we could provide the answers.
Thank you, Minister. It's more or less 1 week that you are requesting. I will really try for the 19th, however, because that being the closing of this Parliament, we have already kind of packed the 19th with some meetings, but we will definitely try to see if we can do it before. So really the 18th or the 19th, and if not, it will be shortly thereafter. But thank you for your suggestion, Minister. Our Secretariat will be in touch with you and your office regarding the scheduling of the continuation, and we therefore will proceed as proposed. So, Minister, I want to thank you once again for your presence here today and the presentation on the GHI, NHI, SAAHA, etc., But what we do know that it encompasses is the is universal health care for St. Martin, coverage for everyone on St. Martin, and that is, in my opinion, one of the most important topics at this moment for us and for the community of St. Martin. So again, our thanks to the Minister, my thanks to the members of Parliament who attended this meeting, and to all tuned in. I wish you all a blessed and pleasant weekend, and I hereby adjourn this meeting until further notice. Meeting